Good morning, Assalamu alaikum. Welcome to the lockdown series during this quarantine time. And today's topic will be oral infections with surgical significance. Before we start with this oral infection and spread, we will discuss about the biofilm, which is the basic cause of infection, especially in the oral cavity. Okay. This can be defined as indefinable microbial community, which was a term coined by a few of the scientists in 1899, and it consists of proteins and salivary glycoproteins. As shown here, there is the tooth surface and there is a salivary pellicle over that. Over that, the salivary glycoproteins do attach as soon as we start our day, and over that the gram positive and the gram negative organisms, cocci and rods and filaments all attach and they form an ecosystem. On the right side of the picture there is a list of all the organisms. This clinical picture here shows that there is plaque accumulated and which can demonstrate up to 400 different species, and per milligram of plaque it can contain 1000 bacteria. There can be two types of plaque, that is supragingival plaque and subgingival plaque, as demonstrated in the picture 1 and 2. What happens as soon as we do our brushing is the saliva glycoproteins start depositing over the tooth surface, and then it appears like a thin pellicle as shown in the picture here. This is the first step in dental plaque formation, which consists of gram-positive bacteria, that is Streptococcus aureus, mutans, viridans, all this, and then it starts growing. The bacteria starts growing, and one bacteria can grow up to 1 billion in a day itself, and they start colonizing over that area. The next step is that they start recruiting new bacteria by a process known as quorum sensing, that is secret signaling within the organisms, and attract a lot of gram-negative organisms like Fucibacterium nucleatum, Prevotella intermedia, and all others. So after a week of initial stage, anaerobic organisms also grow in, and then they take the most deepest part of the plaque. The most common infection in the maxillofacial region is the odontogenic origin from the tooth, originating from the tooth, and they usually spread through the anatomical spaces where there is least resistance, that is in between the fascias and in between the muscle. They start spreading. However, all the infection are polymicrobial, but in odontogenic infection it is Streptococcus aureus on Staphylococcus mutans very common. The necrose pulp creates an inflammatory response and in the apical bone, and then stimulates the cellulus of molasses, which can irritate and causes cyst-like lining. This might be a tooth and a pulp getting inflamed, and the cyst starts growing thicker and thicker. The inner part, because of lack of nutrition, starts necrotizing or dying, and the cells throw out the protein, which increases the osmotic concentration, which imbibes a lot of water, leading to expansion of the cyst and exerting a lot of pressure on the bone, which causes resorption of the bone along with inflammatory cytokines. There are 4 stages: inoculation, cellulitis, abscess, and rupture of the abscess can cause sinus tract and fistula, and then spread to the surrounding or the adjacent tissues. Cellulitis can be a painful swelling of the soft tissues, and abscess will have a well-defined border. Pus is accumulated in the tissue and it is fluctuant, whereas the fistula is a drainage path or abnormal communication. A fistula is a pathway or abnormal communication between epithelial lined surfaces, and the sinus tract is abscess rupture to produce a draining sinus tract. Etiology is most commonly the odontogenic infection where periapical abscess and pericoronitis, periodontal abscess contribute. Non-odontogenic can be due to traumas, secondary to the surgery and secondary to other pathologies. The factors influencing are microbial factor and the host factor and the anatomical factors, whereas the microbial factor is due to the virulence of the bacteria, host factor is due to the general health of the patient, and local factors, that is anatomical, is due to it may be due to the spaces present, and it can be due to the thickness of the cortical bone, because maxillary bone is different than mandibular bone, and these are potential spaces from where, as you see the picture on the left side, the first one, it has some infection, periapical infection, but it has gone through the lingual aspect of the mandibular bone because the bone was weak and least of path resistance. And clinical picture also shows the same thing. Lower two pictures show that the infection has seeped into the submandibular area and the buccal area, buccal spaces or the submandibular spaces. So they take the path of least resistance. So when is the surgical intervention necessary? It is usually when it has crossed the space or the confined space for the infection and it is going to the adjacent spaces, then a surgical intervention may be necessary. Not all things need surgical intervention. If it is very small, it can be treated by root canal treatment or other conservative approaches. But if it crosses the barriers, then a surgical intervention may be necessary. As shown in this picture, three pictures show gingival or periodontal abscess which have endoperior lesion and need to be drained off, and affected teeth to be treated by RCT. But it may not end there, so it may need a surgical treatment known as apicectomy, where the cyst is exposed, cyst lining is removed, and retrograde filling is done by either MTA or other products, and then the tissue is sutured back. The potential spaces can be divided as primary and secondary. The primary maxillary spaces for infection can be canine, buccal, and infratemporal, as shown in the picture here. The potential spaces are retropharyngeal, lateral pharyngeal, mesenteric, pterygomandibular, sublingual, submental, and submandibular. So going to the life-threatening conditions, according to the severity, we start with canine space infection. The boundaries will not be discussed here, but the etiology can be canine or the upper first premolar, which can cause a swelling of the cheek, and this infection can ascend upwards towards the orbit. The problem there will be that the orbit have valvulus veins, and this infection can migrate into the cavernous sinus area. So the clinical features are the swelling of the cheek, lower eyelid, and the upper eyelid, drooping of angle of the mouth, nasolabial fold will be obliterated, and this can go into the cavernous sinus, causing cavernous sinus thrombosis, which is life-threatening. This may need urgent incision and drainage and antibiotic coverage appropriately. These are the symptoms of cavernous sinus thrombosis, starting with mild headache to severe headache up to the seizures. The picture on the right side shows the location of cavernous sinus and the transection of cavernous sinus showing internal carotid artery. These are the protocols to treat the cavernous sinus thrombosis patients. You can pause the video and have a look thoroughly into this. And aseptic measures of CST. So usually it is Staphylococcus aureus which is commonly involved in 70% of cases, and it can be treated by either penicillin or third generation cephalosporins. The second most life-threatening issue is Ledwin's angina, which involves all the three spaces, that is both submandibular, sublingual space, which can cause cellulitis and which can compress the floor of the mouth, causing the tongue to elevate, and compresses the neck also, where airway can be compromised. This is one of the emergencies which has to be addressed as soon as possible. So clinical features: patient may have pain or tenderness over the floor of the mouth, difficulty in breathing and swallowing, redness of the neck and swelling of the neck, and if not treated, intraoral features can be trismus, so floor of the mouth raised, and if not treated, death can occur due to airway compromise. So the management is airway should be managed first with tracheostomy or cricothyroidectomy with the parenteral antibiotics, surgical decompression, hydration of the patient, and removal of the cause. You can see the picture how the incision and drainage has been done, even though it is a cellulitis, to decompress or relieve the pressure on the tissues. These are the routes where the infection from the lower third molar can go around. So it can go to lateral pharyngeal, buccal space, sublingual, submandibular, and sublingual spaces. So lateral pharyngeal space is the third most problematic one. It is present according to the picture. It is present just lateral to the pharynx. And the important structure there is that there are some important structures, that is carotid artery, internal jugular vein, where if the infection seeps, can erode or cause erosion of these major vessels. So etiology is it can be from the infected third molar area, tonsillar infection, pharyngitis, and parotitis. If this infection is not contained or treated, it can go to retropharyngeal spaces, or it can also go to peritonsillar space. Coming to the systemic and the local features seen in most of the swellings is that the temperature is high, pulse rate and respiratory is higher, whereas there will be dehydration and malaise and pallor, lymphadenopathy with increased WBC count. Local features are patient will have pain, gingival inflammation, pus or purulent exudate coming through an opening from the fistula probably. There might be trismus. So going to the most common space to be affected is buccal space infection. The boundaries are there. You can pause and check the boundaries. What I want to emphasize here is that infection from the upper and the lower molars or the premolars can seep into this space, which is between the skin and the buccal muscle. It happens to be in a C shape, and it has tension duct and facial artery in that as a content, a vital structure. So clinical features: it has there will be obliteration of nasolabial fold, angle of the mouth shifted to the opposite side or compressed probably, swelling in the cheek extending to the corner of the mouth and sometimes can extend downward, depicting as a submandibular infection. Next, going to the submental infection or submental space infection. Etiology is that infected mandibular incisors, anterior extension of submandibular space. Clinical feature is raised floor of the mouth, and treatment is incision and drainage. Sublingual space is above the infection going above the malleoid muscle, and contents are submandibular gland, Wharton's duct, sublingual gland, lingual and hypoglossal nerve, and terminal branches of lingual artery. Etiology: it can be mandibular premolar and the first molars. There will be swelling and raise of the floor of the mouth, elevated tongue, pain and discomfort while swallowing. So the treatment is incision and drainage. The second most common is the submandibular space to be infected. Usually the content in this area is the submandibular gland, Wharton duct, lingual and hypoglossal nerve, and branches of facial artery like palatine, tonsillar, and glandular arteries. Etiology is that infected mandibular second and third molar can cause this swelling, and infection from submental and sublingual space can also come across. This infection can spread to the contralateral side, causing Ludwig's angina, or can go to the lateral pharyngeal spaces. The treatment is as usual incision and drainage, which we'll be discussing later. The next one is the mesenteric space infection, which is between the masseter and the mandible, which is a very small area. But the problem here is it causes severe trismus, as shown in this picture. Even though the swelling is not too huge, there will be severe trismus and severe pain due to the swelling of the muscle. Now going to the procedure of drainage, incision and drainage procedure. It is very necessary to do this in any case of abscess. It can save a life, but the first thing is we need to have detailed medical history, and we need to have the knowledge of anatomical structures present in that area. So superficially at the lower, the incision is usually given at the superficial and the lowest point, so that the pus can drain according to the gravity. So if we are giving an extraoral incision, then we need to give an incision in the present skin crease, so that it is aesthetically acceptable after the swelling goes down. If it is intraoral, we need to keep in mind about the anatomical structures. After incision and drainage, incision and compression, a hemostat, a curved hemostat preferably, is inserted, and multiple cavities are broken down so that the remaining pus is evacuated. And then a rubber drain is inserted into the cavity and stabilized using sutures, as shown in the picture here on your right side. So the important part of treatment is to remove the causative tooth or causative agent, whether it is foreign body, or it might be a tooth, or it might be a silolith, or it might be an infected sebaceous cyst. Administration of antibiotic is very necessary to clear off the infection and reduce the inflammation and control the pain by using analgesics. Okay. This is a table showing all the possible spaces which can be involved and their clinical features. And this is the second table showing the same. And the problem here, if it is chronic, it can go into sepsis, which has been termed as the most common cause of death. This is a flow chart to for your diagnosis and treatment planning. If a patient has pulpitis, it can go into septicemia or cellulitis or osteomyelitis if it is acute or chronic. If it is chronic, it can go into osteomyelitis. So the problem has to be identified and treated as soon as possible. This is the protocol if a patient has a facial space infection, the type of investigations, and the protocol and the steps to be done in case of facial space infection. Kindly pause the video wherever necessary and have a detailed